Hi, everyone, and welcome to this training. This is the pain management and assessment and the critical role it plays in end-of-life care. So as you can imagine, pain is a huge concern for people at the end of life. We don't want to be in pain. And I will tell you right now that no one needs to be in pain. And this is specifically at the end of life. What is the critical element here is the assessment of that and the person who's managing that, the caregiver, their knowledge base on this and how pain works. So pain is actually something that works on a way that goes up. So it's on this kind of incline in how it works in the body, how it starts to get more and more and more of a heightened level of pain. So I'm going to give you the tools to use to assess people's pain and how, again, to manage it in the best way possible. There is a 0 to 10 pain scale that we use to gauge because pain is subjective. And so everyone's idea of pain and what is painful to them is going to be different from person to person. So we want to do that on a subjective basis, meaning that I want to treat how you are feeling. So what we want to ask people is, on a pain scale from 0 to 10, 0 being no pain, 10 being the most unbelievable amount of pain that they could ever experience, what are they feeling with their pain? And the way that we want to care for somebody in its therapeutic way is keeping pain at a 4 or below on the pain scale. Now, this is critically important. When pain is increasing, so somebody has some pain, it's getting a little bit more, it's going up almost on this kind of incline like this. You have got to get that pain taken care of with medication or whatever you're going to be doing, and usually it is medication, before it gets higher than a 4. So you've got to get it on the way up. Now, here's the mistake that many people make. We have patients at end of life who have lost control, what they perceive, and understandably so, over their life. And they don't want to be knocked out, number one, about pain medicine. So we want to educate about that a little bit of medicine to bring the pain down, not to knock somebody out, but to bring it down to a 2 or a 3 so they can enjoy their day is the goal. And that's really important. But also that people wait because they don't have a lot of decisions they feel that they can make. And that's why with Doulagivers, we really allow the patient to make as many decisions, except for safety. We can't negotiate on safety, that they possibly can, giving them back control. Because one of the things that I have found as that nurse is that sometimes my patients will just deny wanting to take the pain, just saying no to the pain medicine, because that's the only choice that they have of things, whether I take my medicine or not, to their detriment. And so what they sometimes will do is wait and wait and wait till that pain, they just can't bear it anymore. And they say, okay, give me the medicine. And guess what? It won't work then. It is very difficult to bring pain down. Once it gets away from you, it's very difficult to bring it down. The key is to get it as it's rising, to cut it off. So when somebody is saying, yeah, it's starting to be a 3, a 4, it's getting a little, that is when pain medicine should be given and then assessed. So you want to, about after somebody has a pain medicine, within about 30, 45 minutes, you want to assess what number they're at then, because the body has had time to absorb it. That is going to tell you the effectiveness of that medication, and you can do a really good gauge on that. Why is this important at the end of life? Because pain is going to change. Maybe tumors are growing, maybe it's hitting nerve, maybe cancer metastasized to the bone is creating another type of pain. So you want to know that we have got to continuously be assessing somebody's pain and staying ahead of it in the management department so that the person can have the highest quality every single day. So I will recommend this, to have a book, to have a booklet, and to say what time that medicine was given, what number the pain was from the person, and 45 minutes later, what was the number then, so that you have a really good gauge on what's working, what's not working. Why? Because many people that are different are going to come in and out of that house. And sometimes we forget exactly when the last medicine was given. This is a really good way to have a logbook to keep things straight. So the other thing that I want to share with you is the assessment of the type of pain. So there is somatic pain, which is the most common that narcotic medicine helps, but then there's nerve pain. And nerve pain is something entirely different. It deals with the nerves. It's like a fiery type of pain or a stabbing pain, or people describe it as fire ants. And I'm going to tell you right now that you can throw as much narcotic medicine at the nerve pain that you want. You're never going to take care of it. It will not touch it. It will start knocking people out. They will get really drowsy. It won't take care of that fiery nerve pain. So if you have a loved one or a patient who is having pain and then describes it, again, the first indicator that we know is that when they have a narcotic medicine or some type of thing that's not touching it, then again, you want to really ask them, what is the pain like? Is it a dull? Is it an ache? Is it stabbing? Is it fiery fire ants? When it is a nerve pain and they describe it as such, you need a nerve medicine, something like Neurontin, also known as gabapentin. You can put as much narcotic into somebody that has nerve pain and it won't touch it. And nerve pain is really, really painful. So again, this is about great symptom management, close symptom management, and trying again to strive for the highest quality every single day for not only that patient, but for that patient's family as well. My name is Suzanne O'Brien. This training was pain management and assessment and the critical role that it plays in end of life. Thank you so much. I'll see you in the next training.